So, thank you very much for this opportunity, for this big opportunity in this pandemic situation you gave to me. Uh, I'm going to talk about a retrospective evaluation of intravenous immunoglobulin usage in our hematology practice today. This is also an published article from us, from our hospital, uh, on retrospective evaluation of IVIG usage. Sorry. Intravenous immunoglobulin preparations have been used for many years in the treatment of many disorders. It finds itself a place within multiple indications, especially due to its effects on the immune system. The first usage was first in the United States in 1981 with the approval of FDA. This was a replacement therapy and has been used in different indications with the detection of anti-inflammatory and also immunomodulatory effects over time. The mechanism of action lies in binding with this FC receptors of the system or preventing the immune complexes from binding this FC receptors. In this way, pro-inflammatory mediator and cytokine release of macrophages are prevented. It's known to have regulatory effects not only on the molecular system but also on T and B cells. The main effect on B cells occurs with using different mechanisms. It suppresses antibody release of B cells, neutralize autoantibodies, and also all of almost all of immune complexes. Uh, it has also been found to have effects on T cells that inhibit proliferation and activation. In addition, dendritic cells, which are known to have a very strong effect on antigen presentation, are inhibited through the usage of IVIGs in especially higher doses. It inhibits also the release of many pro-inflammatory cytokines such as interleukin 4, 5, or TNF alpha. It prevents complement system activation with C3b and C4b inhibition. With this emergence of these inflammatory effects, IVIGs, which are included in many indications, are also preferred in patients with hematologic or hematologic benign or malignant disorders at different dose and different usage frequencies. Although it's seen that the most common indication from literature and in our daily practice is immune thrombocytopenic purpura and its emergency treatment, it's obvious that the frequency of usage in different situations is increasing. In our study, our goal was to analyze the usage of IVIGs in our clinic practice retrospectively and obtain a descriptive and retrospective data. It was a study between January 2010 and January 2020. The total number of patients using IVIGs was 166. Indications for IVIGs we may follow. The main purpose of our usage for IVIGs was immune thrombocytopenic purpura, of course, ITP, and then comes CLL, MDS, aplastic anemia, and such as Hodgkin lymphoma or non-Hodgkin lymphoma, myelofibrosis. We will talk about on this theme. Patients who applied to the emergency department or hematology outpatient clinic with thrombocytopenia and who were treated as immune thrombocytopenic purpura at firstly, and who took IVIG together with different dose of steroids according to the emergency treatment plan, received different doses at their advanced examinations. Therefore, patients were divided into two groups, those who were diagnosed before and those who were diagnosed after using these IVIG preparations. It's very important to note that different doses of steroids have been used together in all cases, which are thought to be of course, immunogen. Patients with the diagnosis of ITP were refractory cases under different doses of steroids. And also, it was observed that similarly different doses of steroids were used together with IVIG. Except for steroids, there was no patient diagnosed with ITP who received another type of immunosuppressive therapy. For an autoimmune hemolytic anemia patient, methylprednisolone was used in those that were tried to be reduced starting from 1 milligram per kilogram for 2 months. Afterwards, weekly rituximab treatment was started due to recurrence, but there was no response. This was also a unique case. 66 of 166 patients, all of patients, were diagnosed with ITP. The main diagnosis of our patients was the ITP, of course. Disease and general distribution of patients are given in table 1. This is a table from our published article. We should emphasize that all patients for whom IVIGs were used before getting primary diagnosis were thrombocytopenic. This is an important point for us. This usage was indicated in emergency conditions and emergency treatment. In this context, we see that the number of patients who were used IVIG before getting primary diagnosis was 79 patients, and 41 of whom were diagnosed with immune thrombocytopenic purpura. When we look at the usage in patients which have a primary diagnosis before getting IVIGs, out of 87 patients, 25 patients were diagnosed with ITP. This is also a very important point of our article, our study. Besides primary disease, the indications for IVIG usage are given in table 3. This is a table about patients which were using IVIGs with indications with, of course, primary diagnosis. This is very important. This was also a very important contribution to the literature. Immune thrombocytopenia is the main purpose in all cases diagnosed with ITP. It was used in treatment of immune thrombocytopenia in 4 of 17 patients with CLL, secondary hypoglobulinemia, hypogammaglobulinemia in 11, and autoimmune hemolytic anemia in 2 patients. This is an abstract of usage in CLL patients, in our patients. Sorry. It can be said that these rates are in line with, or are also parallel with the literature. Although different figures are mentioned in various publications, CLL-related autoimmune origin thrombocytopenia is reported on average around 20 and 25% of patients. The patients and their distributions were evaluated according to the targets determined for the response. The expected response was 36.1% with 60 patients within the entire patient group. In 108 patients, the target response could not be obtained. In the ITP patient group, the response was 56.1. The response was 58.5 with 25 patients in patients who were not diagnosed with any disease subgroup before getting IVIGs and were diagnosed with ITP with urgent and also deep thrombocytopenia after IVIG usage. In patients who were diagnosed with a primary disease prior to usage of IVIGs, considering the, of course, various indications, usage and response mentioned previously, 56% with 13 patients in ITP. This is also an important point to emphasize. You may also follow in table 6 responses with primary diagnosis and also diagnose subgroups. Table 7 shows the patients used for prophylaxis. This is another uh, subject of IVIG usage. The distribution of patients who were preferred for the treatment of secondary hypogammaglobulinemia, and secondary immune deficiency can be seen. Out of 21 patients, 6 were diagnosed with multiple myeloma, 6 with CLL, 3 with non-Hodgkin lymphoma, 1 with Hodgkin lymphoma, 3 with common variable immune deficiency, and 2 of them were diagnosed with sickle cell anemia because of autosplenectomy. IVIG products appear with a wide range of indications in our current clinical practice. Our study contributes to the literature retrospectively by revealing data of our clinic. Important data have been revealed for the use of IVIG preparations in our practice, especially in the patient group before primary diagnosis. It is important to reveal the experience and to observe the responses carefully in terms of emergency approach to thrombocytopenia. It contains important data in terms of treatment and also approach. In the literature, data on similar clinical conditions, emergency situations, and their primary diagnosis are very limited. Another important limitation in our study is that steroids were used in different doses and types in addition to IVIG preparations. For patients who use IVIG for immune thrombocytopenia, and therefore it's not possible to make a statistical analysis between the patient groups and also subgroups. Many hematologic diseases and alloimmunization have been reported in the literature. In particular, hemolysis and thrombocytopenia, which lead to frequent alloimmune-based replacement needs, are clinically very, very important. Although different rates are reported in the literature, we see that alloimmunization targeted IVIG use is only against thrombocytopenia in our patient group. Treatment success in these cases also results in a low rate, which was similar to the literature. Especially in the MDS group, there are studies with a wide array of alloimmunization, ranging from 15% to 59%. However, it is necessary to state that there are serious restrictions on treatment and outcomes in these study groups. Optimization of the results is seen as the biggest problem. In our hematology practice, IVIG can be used in case of immunodeficiency, often secondary to malignant hematological disease, or immunochemotherapies, which we prefer. In addition, immunosuppressive agents, malnutrition, and aging cause also the development of secondary immunodeficiency. Life-threatening infections may develop. IVIG products stand out with a wide range of effective usage and are frequently preferred. Our study contributes to the literature retrospectively with revealing our patients' data, content standardizations,